for her to look at. Well, good afternoon, or good evening. Welcome to Backyard Bootcamp Aortic Series brought to you by DeBakey CV Education. First off, I'd like to gratefully acknowledge the educational grant to support this activity which came from Medtronic. So once again, what we're going to focus on this afternoon is stroke, TEVAR, and transcranial Doppler, something that we feel very strongly about. And I'm going to kick this off, but I'm joined this afternoon. To my left is Dr. Kavya Sinha. She's a postdoctoral fellow who's done research and done a lot of work in transcranial Doppler. And to my right is Dr. Zsolt Garami, and Dr. Garami runs our vascular ultrasound lab. He's really one of the world's experts in transcranial Doppler. So again, thank you for joining us. Let me kick it off and kind of set the scene of why we kind of got interested in this. It doesn't matter if you're working on the left side of the heart, thinking about ablation for AFib, mitral valve interventions, and of course that's about to undergo an explosion in terms of percutaneous interventions. Whether you have a heart attack and you have a clot in the left side of the heart, the aortic valve, or if you start working up in the aortic space, which is going to be the focus this afternoon. The complications of all of these are embolization and particulates, which ultimately can go on up into your brain. Probably easily the most feared complication from all of these different kinds of interventions, because the flow goes downstream and the brain is essentially an end organ and particles can't get through the circulation that we get up there. It's often surprising this didn't happen more often, but we're going to come back and talk about lessons that we may be able to take from TEVAR, because there's a significant instance of embolization. And when you look down at a calcified aortic valve like this, little wonder that actually occurs. But we're not immune from looking at the inside of the aorta. Again, when we think about driving big devices, wires and catheters up over the aortic arch, again, it's surprising that we don't get more embolization than we actually do. Likewise, if you look on your to the left of your screen, this is a thrombus, which is intraluminal in the carotid artery. And again, it's why embolic protection was essentially developed. This whole idea that carotid stenting was approved for reimbursement only with the concurrent use of an embolic protection device. Why? Because without it, there was a high incidence of embolization. So a lot of the lessons that have been learned from the carotids can now be moved and applied with the development of embolization protection devices for TEVAR. And we're going to examine some of the data for this. So a couple of years ago, with this new classification system for endpoints in cardiovascular clinical trials came out from the Academic Research Consortium Initiative. And this was focused, and there's a who's who in TEVAR clinicians and neurologists from around the country. And again, in the summary statement, they basically said stroke is amongst the most feared complications of surgical and transcatheter cardiovascular interventions, and ultimately affect both the costs and the risk-benefit analysis of undergoing one of these particular procedures. And what they did was they actually looked at the different type of events that could actually occur. And where we work is in this area of embolization. Clearly, there are groups of patients who have big emboli and clinical symptoms. But a lot of the focus is on those patients who have evidence of embolization that affecting their brain and may not have clinical symptoms. In other words, they have subclinical brain lesions, this DWMRI positive lesions. To this date, we're not entirely sure how significant that is, but one of the arguments I always make is, are you better with no emboli or emboli that you don't think are significant? We'd argue that no emboli, of course, is clearly a lot better. You're a lot better off. And when you drew this pyramid and you look basically at the events, then there are the type 1 injury, this is overt injury, this is a clinical stroke. And what we're going to be focusing on is this type 2 injury, which the argument is this is the overwhelming majority of cerebral events that actually occur, where you have embolization to the brain, and yet the patient appears clinically and functionally normal. And that is almost certainly due from embolization or microembolization. And where we're focused on transcranial Doppler is how can we analyze when this is actually occurring. So here's the problem. In situations, for example, when open heart surgery, patient goes to sleep, procedure is performed, patient wakens up with a stroke, and we want to fix something. Problem is, what are we going to fix? Is it because the patient had the aorta clamped? Because they're put on cardiopulmonary bypass and there was air in the circuit? Is it was the decannulation was occurring? And very similar trends occur if you're using placing thoracic stent grafts or TEVAR. Often these patients are sedated. We waken up and they have an event and we want to fix it, but we don't really know what part of the procedure has caused the emboli, and we don't therefore know which part of the area of the procedure to focus on and try and fix. And so when we're talking about thoracic endografts, the engineers really want to know when these events happen so they can focus on it. And we'll show you a little bit about this. And so we believe that you've got to be able to isolate all of these procedures into their component parts. And we talk about embologenic phases of the procedure. And only by analyzing it in this way and having some real-time method of detecting emboli can you actually start to troubleshoot and to fix these procedures. So of course there's a lot of ways of performing neuromonitoring. You can do EEG, we can use INVOS, and all of these things will tell you only if there are major disturbances basically in flow to a hemisphere. It'll certainly detect that, but it doesn't detect emboli. Emboli or embolization is the most common reason, and so these standard accepted forms of neuromonitoring don't tell you anything about the most common reason that patients actually have a stroke. And it's one of the reasons that we've got heavily interested in embolization and stroke. Transcranial Doppler will tell you several things. It will tell you about flow. Is there flow? Is there no flow? Or is there a change in flow? It'll tell you about flow direction. So for example, you block off a carotid artery, you can actually real time see compensation occurring. And it will tell you about embolization. So these, and it'll also tell you about hyperperfusion. This is more related to the carotid world when we hyperperfuse after removing a high-grade stenosis, for example. But these are all the things that transcranial Doppler can tell you. And I'm going to argue that all of these things are highly relevant when we're actually placing endografts in the aortic arch. And the further over the aortic arch we go in the zone 0, then the higher the incidence of stroke, which is going to limit the application of this unless we figure out basically how to solve some of these problems. And so this is an example of a thoracic endograft being placed. If you look at the transcranial Doppler, the recording that you see, what the top line is basically showing you when emboli actually occur. And we're going to go through this, in a lot more detail. And the Doppler signal basically will also show you what the Doppler signal is, but very similar to actually putting a Doppler probe on somebody's dorsalis pedis arteries, telling you about the flow that is occurring in those target arteries, in this case, the middle cerebral artery. So obviously there's been a lot of concern about embolization occurring as a result of these advanced interventional procedures. We published this paper, and I think Dr. Garami is going to go into this in a little bit more detail many years ago now, looking at TCD findings during thoracic endovascular aortic repair. But obviously, TEVAR has become the big dog, and TEVAR really has brought a lot of focus on it to the point that there are a number of trials being run at the moment trying to emulate what was done in the carotid world. In other words, using embolization protection devices. But there's some confusion really in what that data actually looks like. I think Kavya is going to focus on that to some extent. And when you're doing really complex procedures like putting a stent graft, you're also replacing the ascending aorta, you're rerouting all the grafts, then these are patients who are just, a setup for embolization. And we use transcranial Doppler monitoring in all of the patients that were actually, who were doing these kind of procedures on, as long as they've got a window. So a few years ago, we were kind of asked about the value of TCD, and the reason is in TEVAR, and the reason is essentially this. In multiple different trials, if you do diffusion-weighted MRI imaging, which is probably the most sensitive way of looking for early onset reversible ischemic lesions, then nearly 78% of these patients have lesions in their brain. 78%. Of lesions which you can identify in their brain. Now, I'm not particularly fond of I don't have that many neurons to spare, quite honestly. And so this is really what has driven this profound interest in trying to mitigate this as we go forward. The actual clinical relevance of this is also something that is currently being evaluated. And that, of course, has led to the development, basically, of multiple different ways of trying to protect this. The problem is you've got to get them in there. Now, whether you're going to protect all the aortic arch, the entire aortic arch and supraortic trunks, or you're going to, like, for example, Sentinel, protect only 2 of them, now moving, I believe, in the future to trying to protect all 3 of them, there's clearly risk associated with this. And this is one of the things that we've been looking at. I don't think we can share any data with you, but from the recent presentation, looks like Sentinel doesn't potentially reduce the entire risk, but it may shift it. And so one of the things we're interested in is if you can establish the embolization protection, is it then effective? Even at the cost of causing embolization as they are actually inserted. The solution to that from an engineer standpoint, of course, basically is fundamentally different. So I'm going to give you 2 examples, 2 great examples of the value of TCD. And this is a patient actually, I believe, is having a carotid stent placed. No, TEVAR. Was this a TEVAR? TEVAR. And all of a sudden, basically, the patient has a cardiac arrest. And what happens is we're monitoring the cerebral circulation, the middle cerebral artery. And you will suddenly see a pair of hands coming in, and the hands will start doing CPR. Fortunately, Dr. Garami was actually monitoring cerebral flow. Now, just imagine how often this may actually happen when patients basically have CPR basically on the floor, okay? CPR is in progress. You look in the room, CPR is being performed. There is no flow in the middle cerebral artery. And so the resident who's performing that gets yanked out of the way, and all of a sudden the surgeon comes in and really starts doing CPR with some gusto. And what does that do? It reestablishes the cerebral perfusion. And so just because you bounce some of your hands up and down somebody's chest doesn't really tell you anything about middle cerebral artery flow. TCD can potentially tell you that. Not arguing this should be done in a code situation. What I'm telling you is it tells you about the effectiveness of cerebral perfusion and our ability to resuscitate a patient. Now let me talk about emboli, and let me set this up. This was actually off-pump coronary bypass being performed by one of my partners, Dr. Mahesh Ramchandani. And this is stabilizer, the artery is open, and then what you're going to see is the way you clear blood from the field is you're going to see what's called a CO2 blower is going to come in on the field. It blows CO2. There you go, it blows CO2. And then what happens? Immediately you see these gas bubbles coming up into the head. This probably happens in every operation, but I happen to be monitoring here, and you could immediately tell that cerebral embolization is occurring. So the reason for showing you these 2 examples was this latter one showed you about the immediacy of detection of embolization, and you do what you can to make that stop. The former one shows you about flow and how it can tell you basically about flow. You block off a carotid artery, for example, when we're deploying the thoracic endograft, you will immediately see diminution of flow, and then you can evaluate it for the amount of recovery. So this is real-time MCA target helps you. And so we've taken this basically into the lab. We have a number of different models here by which we can actually try to emulate some of this in cardiopulmonary bypass. We have this aortic arch flow model. What we're trying to do is set up these models by which we can test embolization protection devices. Most of them have porosity around 110, 130 microns. When you get much below that, I believe there's one that's a lot below that, you start to get a problem with thrombosis. If you go much above that, then you get these particles. And so we really don't know what size of particles you need to prevent or need to filter in order to prevent having lesions basically up inside your head. So here's an example. Let me go back one, and let's set this going. And so bottom right, transcranial Doppler, middle cerebral artery, right side, bottom tracings, left side. This is a branched endograft. And you can see the wire. These are all fusion marks, by the way. We always use image fusion to help guide us. You deploy it, and then what happens is immediately you get this massive embolization. Now the question is this gaseous or is this particulate? To this day, you can't really tell the difference of that very easily. You're going to hear from Kavya a little bit about some of the techniques that we use to try and get air out of there. But you deploy the endograft, you immediately see what happens inside the head. Not a lot you can do about it in this situation, although there may be better methods of actually flushing out the endograft that are being tested in the future. But this just shows you the value of this. And so the problem is that we need pre-op imaging for identification of embolic risks, mobile plaque, calcification scores in the aorta, what's the peri-procedure anticoagulation. There's so many different things which can be used to try and address this problem. But at the end of the day, I want to know what happens inside the brain when I manipulate devices inside the chest. That's what we're really trying to show, that we can link between transcranial Doppler and monitoring the brain basically in this kind of way. So I'm going to hand you over to the guy who knows more about TCD than I will ever know. I'm going to keep this.
Yes.
And Dr. Garami is going to walk us through transcranial Doppler and try to convince us why we should all be using this.
And just please use your pointer if you want to highlight anything during the procedure, please. And I need your translation, because I think my mistake is that sometimes I'm just overshooting with my easy comments on those cases, what we've done. So please just help me to really translate our findings. First of all, thank you again for joining us. And what I would like to show you, what is the problem with the TCD? The TCD is available probably about 100 hospitals in the United States. There is more demand. If you would like to do a comprehensive stroke center accreditation, you need to have a TCD in your hospital. The second part is how often do you use your TCD and who is trained your sonographer. Those are the limitations. Again, machines still a limitation. You can use some machines that they may not give you the same signals, and that's when you call no temporal bone windows, no temporal bone windows. If you have 50% or more, be suspicious that there's a technical error there. The normal values, when we see that we're missing, and especially ladies, they have thicker skull. I'm not sexist, but this is our finding, that about 20% of the ladies has thicker skull, that we having problem getting through the bone with our ultrasound waves. And again, that's our patient selection. So I think the idea is that we need to train our sonographers in the schools, which is not happening, again, because your teachers are not experienced with TCD. The neurology residency program started to pick up some training for our residents. So we do our share training our vascular surgery residents in Houston. This is the one slide I really would like to walk through, that TCD is really not a new technique. This paper is from 1997, and what it shows that if you try to link TCD with carotid endarterectomy, if you had at least 50 hits, it's correlated very well with the stroke. But I think it's pointing out another interesting finding why the TCD is really difficult to read, that you see A, B, C. These are three readers. They could not agree with a number of emboli in none of these cases. The only time they agreed is when you had a 40 emboli shower. So we are relying on equipment counting your shower, but I think still we have our limitation, and even today we need to manually count, because again, when you have a shower, the machine cannot count them. We are relying on a number of heartbeats actually counted as a shower, and we try to estimate. Basically, we are doing the best estimate when we have these emboli shower. We have no clue when you just have like a whiteout that how many really emboli you see. And again, the limitation, you will hear a little bit more. What are the smallest particle we can pick up? It's probably somewhere with a 10, 20 micron range. So again, my signal, what you're going to see on my TCD, is reflecting from the red blood cells. If anything else traveling in the red blood cells is going to give you this bright line, this is a middle cembral embolus, and we are in Texas. So this is how easy to differentiate a horse and one of those bulls. This is an embolus. This is not an embolus. This is an artifact which appears multiple depth at the same time, and there's no speed because it's sitting on a zero line. When you have a true traveling embolus, it needs to have a speed and needs to travel together with the red blood cells. This is why you need to see it in a waveform. So, okay. Yes, sir.
Can I interrupt? Because let me go through this, because I know so much less about it than you do. But let's just highlight. So this is a screen you look at every day. On the y-axis, this is a depth from the skull. So you're essentially firing an ultrasound beam and God knew that transcranial Doppler was going to come down the line, so he built the middle cerebral artery and the end of the internal carotid artery so that you could see in one ultrasound beam, you can interrogate the middle cerebral artery and the anterior cerebral artery and the anterior communicating artery, and sometimes even the anterior cerebral on the other side. Mm-hmm. And that is kind of, you depict this because that yellow line, you can control that. And so this top part is red because that is the ipsilateral middle cerebral artery. Blood is flowing from deep to superficial. Then when you get to the anterior cerebral artery, blood is flowing away from the skull. So at 60 millimeters, you're picking up the ipsilateral, in this case the right anterior cerebral artery, and blood is flowing away from it, and that's the reason it's blue. And when you set that yellow line, that's what gives you this Doppler pattern. So if you dialed that down to this level, you'd be seeing that Doppler coming from the anterior cerebral artery.
And underneath the zero line. So I think God has also made us not colorblind. So this is a red corresponding with a positive finding above the zero line. If you move it down to 60, the yellow line will represent AC, which would be underneath the zero line. So again, the flow direction, I think, as you said, very important. The TCD give me a low resistance signal in the MCA because the M mode is continuous. So throughout the cardiac cycle, I see flow in the systole and flow in diastole. In a moment this line is interrupted, then I'm in trouble because it means that your middle cerebral artery is occluded.
Can I make one other point? Because this is how you taught me, and I always remember it, is that a particle, think of this as coming up from the thoracic aorta, and it's entering the terminal internal carotid artery. And then it happens to sweep left into the middle cerebral artery. And the x-axis is time. And so there's always a slope. What you're looking at is a particle that is going from deep in the brain to the surface of the brain, and it's always on a slope because it takes time for that particle to go from the terminal ICA up to the surface of the brain, and it's inside the signal. And so that's how you tell that it's an embolus. How'd I do, teacher?
Very good. A+, sir.
Thank you.
So what happens if it's an ACA?
Goes in the other direction.
And it's delayed, so it's going to be a getting away from you. So it's not going to be a forward slash, but a backward slash. So that would be the idea. But another idea, I think, I have problem when we're reading papers and someone just doesn't include any images from the cases. That is really hard to believe. What is the method? And here's the method that. If this is sitting on the zero line, you shouldn't count this as an embolus. Okay. So lots of time just tapping, a really simple thing, just if you start your monitoring early enough and you're just prepping the patient, just touching the skin or any tapping, any sound would be again recorded by the TCD.
But this isn't really, it causes no end of confusion. But this is a remarkably simple concept.
Yes, but I think this is where the problem, when we said the limitation of the TCD, again, we need to train people, we need to understand. It's really objective. What I think, as you said, that when there's no embolus, this whole thing is red, and we are calm, and we say, great case. And when you see a shower, then we are really more on the edge and paying attention, make sure that your signal didn't get lost. And the second thing is, here's an example how you see a very good contrast injection. On the left, you don't see any emboli in it. Mm-hmm. So this is a perfect contrast injection. If you have a little bit of air, this is where you see there is air in your contrast injection. You see the contrast arriving to the middle cerebral artery, and it gets brighter because, again, a different material arrives. And even I would say that if you look at closely under the microscope, you even see velocity drop because the contrast agent is a little bit more moisture, so it's not going to be as liquidish as your blood. But again, this is what you don't want to see, that your signal kind of going down as all the way down, that here's your waveform and your waveform is gone. Okay, so this is not a microembolus, this is a macroemboli that is occluding your middle cerebral artery, and this is like real time. You can bet on this one. If you will wake up the patient in this moment, the patient wouldn't talk to you too much.
So let me try to interpret this for you. Now, this is a little risky to do this live.
This is very difficult though, because you see the depth is cross-insonating. It's cross-insonating, so be careful because
so
it's blue and it's 102.
Okay, so what are we looking at? AC on the other side or MC on the other side?
MCA on the opposite side. So
and this is coming from the MCA on the other side.
Yeah.
And so this is an embolus occurring, and then the waveform diminishes and essentially goes away. And so that is a full large vessel occlusion. Now again, a lot of people will say to us, well, you tell me about this, but there's nothing I can do about it. Well, you can do something about this.
Exactly. Because another thing is, again, you're troubleshooting. Another thing is, hey, head frame is still on the head because you're not still finding with your anesthesia colleagues. One of the things is that your signal is still on because you still the flow. That's your number one troubleshooting. Losing the signal, and I think we're going to demonstrate it later, but your signal, here's your beauty. Here's your MCA, you're uncompressing the carotid. This is the waveform change, what we can see that the proximal blockage generate, and there's your, again, how we are trying to understand what you see in the waveform. And I think the waveform, what we are coming from is from the stroke monitoring. So we validated our TCD signal. What do you see on the TCD signal as a waveform with a total occlusion on the cerebral angio? What you see on the TCD when you have a partial occlusion on the middle cerebral artery, or you have a stenosis, so you have a normal flow. These are beautifully correlating with NIH stroke scale, and this is how we selected patient after a successful TPA that who needs intervention. But again, I would like to show a little bit of data about TEVAR. Because what I think is, which you really infected your friend with TCD, because before he started to use TCD, he had a beautiful paper about what is the percentage of the major event and stroke. And again, when you're looking at any papers, it can be 2 to 6%, but honestly, is somewhere around the range of 20 to 30%. And one of the paper which has really impressed me most is that what I thought that maybe the 0 to 1 has the highest stroke rate, and this is about 200 cases. It's not. So the highest the stroke rate with the zone 2, 3, and 4. So for me, this is a little bit more stunning, and I really wanted to see it in our hand, and this is what we did with our TCD. And what we saw is we tried to divide our procedure, and I had to learn step by step of what the surgeon is doing on the table, what do I see on the TCD. And again, we had to correlate, and this is before we had any fancy video link. We had to just on a paper make a comment what was the TCD time of the same time. But definitely the pigtail on the field is generated embolization. During your treatment, definitely the device deployment is the highest emboli count. And how we wanted to display it here, that again, the pigtail, this is the diagnostic phase.
Can I describe basically the way you got to figure out how do we report this stuff. And so what we've done here is, this is one hemisphere above the zero line, this is the other hemisphere below the zero line. And so each of the cases is color coded. And so essentially when you're trying to make sense, there's two ways of trying to make sense of this. What we now do is we record simultaneously on video, time-stamped what we did down in the chest and what's happening basically up in the brain. Now that makes the interpretation of it easy. We didn't have that at that time. The second thing is to try and so there are a huge number of different steps, believe it or not, in doing these procedures. So what we try to do is break it down into phases. So for example, this one is divided in two broad phases, a diagnostic phase and the device treatment phase. And so you can subdivide the procedures for reporting purposes into doing this. And at a glance, you can see that device deployment was when the showers actually took place. But it wasn't the only time. It was really happening throughout the entire procedure. But clearly one dominated the other.
And again, the pigtail, I really didn't want to believe it. And I'm going to show you some videos that even when you were accessing the groin, I started to see emboli in the brain. But this is, yeah.
But you're going to have to convince me of that. That doesn't make any sense to me. I mean, it's got to be.
It's so objective that I'm
Yeah.
not making this up. So
Yeah.
this is one thing I can do, that definitely I cannot inject anything. So this is why I'm kind of interpreting whatever the TCD tells me.
Yeah.
If I see something on the screen, and I think our understanding is really how
But
we
that's not what this is.
Okay, here, when you see that is crossing, and these are real emboli bilaterally. So I think this is another very important finding, going back to our table here, that what we saw, it was quite bilateral throughout the case. So when you see, I think this is why we wanted to do bilateral monitoring majority of the cases, that we can really monitor both middle cerebral arteries. We came up with some alternative method to monitor posterior circulation. We'll show you some example for that. Here, I think the best example is really just dividing right and left side with, we divided just the zones, zone 0 to 2 and zone 3 and 4. This is how you see the difference embolization.
But dark blue is treatment, isn't it?
Yeah.
So now I accept that you get it, but it's not as high.
But this is why, see, it's not matching when you look at the during the zone 2 and 3. What is the other historic data? But what was stunning, then when you look at our data, we had the correlation with the total emboli count with these p-values, which are scary good in the low case numbers. But what another observation, I think we just put it in a really small letters, but I think it's a very important finding, that if you look at this waveform, this is what happens when you balloon. So look at the shape of the waveform and how the velocity is changing. And when you just see that with a ballooning, how much velocity change you have, I think that is another significant finding for our paper, that indeed your balloon does change your flow pattern in a middle cerebral artery.
So there are basically two different balloons that you can use. So number one, they're completely occlusive balloons. And then what you see is the middle cerebral artery velocity can go up fairly dramatically. Probably not that significant, but in patients who are prone to intracerebral hemorrhage, it may be. And then Gore, of course, came out with the trilobe balloon. The idea was non-occlusive. Actually, even with the trilobe balloon, there's increase in the flow velocities in the middle cerebral artery.
And this was just one more quick data comparison, that we did see some significant differences if we separated our tag and the C tag into two groups. And one of the old TCD did, and this is our friend from UCLA, Dr. White, paper really wanted to show us that when you are watching the middle cerebral artery and you don't see velocity changes, but you see how this waveform changed to more dampened waveform, this is maybe you are confirming that you may blocking the carotid origin. I think this is where it's a really black and white compared to the color. I'm sorry, Dr. White, this is why it's black and white, but the depth. So one of this interesting thing is that you can see is 56 to 50. So try to not to change your depth during the monitoring, because now you cannot really compare those two waveforms anymore. That's just another teaching point for monitoring. But here we are. We are in the operating room, and this is again our TCD from 82. We are definitely in our old suite, and this is where I would say the TCD is still the cheapest technology in our room. And this is how we're putting a head frame on. So this is on a awake patient, because we just wanted to demonstrate how easy to put a head frame on, shovel it on the back, and after you position on the head frame, on the right hand side you will see, I'm just speed up, that this is literally about 2-3 minutes process, but you need to capture you need to capture the depth around 50. 50 is our magic depth, that's only the middle cerebral artery is visualized. So after putting the head frame on, I just want to show you a few of these really interesting cases. Again, we're coming in the groin and I see emboli. I have no option but to describe that with the groin access I saw, and we don't know where the tip of the...
Absolutely. That's exactly what I was going. Actually, many years ago, I got asked to look at a case, a malpractice case, in which a guy was being sued for putting an infrarenal endograft, and the patient had a stroke. And what happened is the wire went up and over the aortic arch, And the argument was the wire didn't need to be up and over the aortic arch. So no question, wires can be. So that's probably what was going on here.
Yes, sir. And this is just a pigtail. But again, when we start a case, this is our new recording that we have a 4-channel able to display for us. Again, operating field.
So this is going to be a carotid subclavian bypass.
Exactly, and I think the point what we started to do with our new protocol to try to divide your procedure into the bypass, and the following day we did the endograft. So this way you can really look at the risk of putting a clamp here. So you see that here's your flow.
Yeah. So you're talking about here.
Yes, sir.
So
your flow is still good, but it's like non-pulsatile, confirming that you have very good collaterals.
Okay, so again, you clamp the carotid, the pulsatility drops, the flow velocity usually drops, and then it compensates. And so you can often watch this compensation occurring in real time. And so, for example, we're doing a carotid endarterectomy.
And see here's the clamp off. See the clamp off?
Clamp off, yeah.
And no embolization. So this is what you want to teach for your vascular surgery colleagues, that yes, you can release the clamp without any embolization, but this is the percentage. Can you point this one with your... So this is the percentage what we are watching. So the delta percentage is pushed as your baseline, and when you put a clamp, now you're putting a clamp on the bottom. I just cannot move this cursor, but on the bottom, no, the clamp is on the bottom. I need to go back and show you guys that one. So what you see, after we done the right side, now we are clamping the left side. You don't see the clamp on the left side because the bar is covering it. Okay. Yeah, sorry.
No problem.
Anyway, here's the clamp placement again, and this is just again finishing up our bypass. You have a normal flow, and again we are trying to really study how the blood pressure control really affects the flow. And here's one more new ways that we try to monitor the posterior circulation in the PCA. So this is left MCA and right PC, because we only have 2 channels. So you need to be a little bit intuitive of how you're going to monitor anterior and posterior circulation. So here you see the left MCA, underneath you see the right MCA, but here I'm able to monitor the blue signal. Now it's the probe point posteriorly, and that's your PCA.
Okay.
And here's again the pigtail coming up, and here is my favorite case. That's sometimes I think you need to do this vertebral transposition and able to see that the PCA monitoring, here's the P1 is monitored, and the left MC is monitored. And I just want to speed up this a little bit. But
so this was a patient who had an anomalous vertebral coming off the aortic arch, and
I'm going to show it right now.
Presumably the one on the other side was
right here. Can you point it out?
Yeah, I can. Oops. Yeah, I pointed it perfectly.
Right there.
Right there. And so rather than sacrifice it, we just kind of reimplanted it.
Yep. So again, this is where the left MC and the right PC monitoring comes into the picture, that you can do posterior circulation monitoring. And I hope you guys are going to recognize this device. And this is again a vertebral monitoring, because we are in zone 4, and we are just wanted to make sure that we are not getting anything into the vertebral. And these are just noise. So again, did not reach the brain, but you see some noise. So you do not see it in the...
How do you know it's noise?
See the emboli here, and you saw this, it did not come to the flow, so you did not see it in the between the red blood cells. So when you look at this a little bit earlier, see this? So your red blood cells did not show up, and you just have, again, embolization not inside the brain.
All right.
And I would like to pass the torch.
Okay, well, so Dr. Lumsden and Garami kind of covered the old school TCD and the operating rooms of the past. And here we are in 2020 with the Walter Awaras and its newest technology and the era of robotic TCD. So here we are, and I will be talking about the NovaSignal neurobot today, previously known as Neural Analytics. So here we are in the newest operating room, the hybrid suite, where we have a 4-channel quad recording ability, where we're essentially recording the vital signs along with transcranial Doppler fluoroscopy, and a room camera that can be switched off for the in-light camera or other input channels that where you'd like to record to correlate to see what's going on with the actual procedure. So what is the Nova Signal neural robot? This is essentially a TCD that automates the operator. What you can do essentially is put the probes onto this patient, and the operator for this patient does not have to be experienced in TCD. This enables the automatic capture of the MCA and also enables us to optimize the signal once it's on hands-free. You can sit back in the hybrid room or wherever you are and control this remotely while this probe's doing all the work for you. So essentially, we have this 5-degree autonomous capture where this essentially is similar to the manual ultrasonographer where we sit there by hand and move the probe around. This can automatically do that, and it captures the best MCA signal available at an ideal depth that captures the best waveform there is. So we're looking at the window discovery. As you all know, the transtemporal window is a very limited window, and we like to try to ideally capture the best MCA signal. So what we do is capture these signals and point them out in this aggregated map that we're collecting where all the high energy signals are recorded to see where the MCA is recorded for most of these patients. We're also capturing the signal optimization in order to highlight where the MCA is captured for most of these patients to kind of make a map that shows where gender differences lie, age differences lie, and ethnicity differences lie. And like I said, this also enables experienced technicians to kind of show us where we're doing this wrong and where we're doing this right. The experienced technicians can come in and show us how the MCA signal is differing between patients. And someone like me who's learned TCD over the past year with Dr. Garami can come in and actually use this in the OR every day and put these on and sit back and monitor during the procedure for these patients.
Can I ask you?
Yes.
I play in Scotland they call it the daft laddie. The guy that doesn't really know anything about this. When you say AMP, these are different windows and different approaches to incinerating. Can you just explain what that is?
Sure. So essentially what we're looking at AMP is this how the probe's being moved. If it's in the anterior position, we're trying to cover the anterior cerebral circulation. The middle is where we're trying to capture the middle cerebral artery, and the posterior is when we're switching the probe so we can capture the ACA or the PCA, and it's angled towards the posterior part of your temporal window.
Can I show you this one? Because I think this is what helps you to really understand. So the machine between these two dots going to put this square when the machine is going to search. And my favorite window is the posterior window. If you feel it on yourself just front of the ear, there's a tiny dent. This is where I believe there's the best window. So now I'm learning from this machine. The machine is teaching me, the expert, that maybe the middle window, it's even better. So this is when you look at the square. Here what you see is that if you look at that square, what the machine is searching, right in the middle, you have a better window. So this is based on 200 patients' data, but I think this is where I need to give up sometimes and need to say that, yeah, looks like the machine is teaching me something that with my 20 years on my belt is still learning from that. So I think this is where the anterior, mid, and posterior window plays a role, how to find the best and the strongest signal, because you do not want to lose that. Sorry.
That's fine.
Yeah.
So to give you a real life example, this is a patient we did in WeVo. We were doing a TEVAR monitoring. So essentially when you put these probes on, the first thing you do is you put these fiducials on that go by your ear and your eye, and that essentially signifies your transtemporal window.
Okay.
So this is where it goes.
Yep.
So when these are put on, the system then initializes, and that takes a few seconds, and then it's able to identify the workspace to work in. So this is essentially what you see here, the workspace. And that's where the likelihood of finding the MCA lies. So then the Lucid system kind of gets to work and acquires your MCA signals while you sit back, and you can adjust the settings as you like, the gain, the depth, and the filter, and whatever else you need to do to get the best signal. So here's another example of what the system looks like. There's two screens. There's the robotic screen here that shows you the workspace in which you're acquiring your signal, and the Lucid screen or the TCD screen that shows you the thing. So here we are showing you the setup of it. This is what the probes look like when they're on. And this is a person essentially initializing, registering, and getting the workspace. And here you are acquiring the signal on the left.
So the anesthesiologist can continue to work with the patient while this thing is acquiring the signal?
Yes,
Yes.
And I think this is our video of the very first case we did, so this is why it's a special thanks to Lucas. So Lucas was really my assistant in this case, and this just shows you how the probe movement is really tested before we put it on the patient, so make sure every movement is initialized, and again, the machine is ready to get the signals.
Okay.
So this essentially, like Dr. Garami was saying, this shows you the 360 degrees of movement that the probe has. And this is our workspace once, we can work in conjunction with anesthesia. Usually we get in once the central lines are in, or when they've essentially put the patient to sleep, done their intubation, put their probes in, depending on the procedure. And then we can get in and have our TCD ready to go.
So this looks like a situation where we're embolizing the subclavian and it's going alongside the endograft.
No, this is after the embolization. No, we are protecting the left common origin. So and this is where you see the partial obstruction of and what I want you to see is when your balloon is going up, watch the screen. I know that your head is starting to cover, but this is where you're going to see the signal change, and again shows you immediately how the balloon going to affect the flow on the left side. So this is your left side, see that? And again, after releasing the balloon, you see the shower of emboli, but nothing on the right side.
So this is a patient where we deployed the thoracic endograft?
Yes.
And the MCA signals immediately went down?
Yes.
That led us immediately to access the carotid and evaluate just how much encroachment. Well, we knew, that's the advantage, we knew how much encroachment there was based upon that. So we were just going straight to place a stent. So it allowed us to act immediately based upon that.
And look at the waveform. So I think the waveform, we always say that the waveform needs to match what your art line. So the upstroke is there, that you know that you don't have any blockage between your measurement point in the brain and your heart.
All right.
So I think the systolic upstroke is our key element, not just the numbers.
Okay, like this shows, this is another setup of the OR, showing you the two screens here. So we've got the robot setup adjacent to the patient. Anesthesia set up here, and we've got the robotic screen and the TCD screen. And that's just showing you the initialization of the robot. And this is to allow the probes moving fully so that when we put the patient in, we don't have any problems.
So the reason we are particularly interested in this is because every time we go out and talk about transcranial Doppler, people go, well, we can't, that's great, we love it, but we can't do it because we don't have the expertise to put it on and we don't have the expertise to interpret it. And so this is tackling one aspect of that, is that you potentially can have an autonomously applied transcranial Doppler probe. And we'll talk about the monitoring of it shortly.
Yeah.
I started to cry when I realized that I no longer need it,
longer
and my
need
job
it.
security is really in jeopardy now.
Yeah. So this slide essentially is showing how, even though you can capture the signal autonomously, you can actually go in and search manually as well. So, for example, if you've done a pre-op for this patient and you know exactly where that MCA window lies, you can go in and find it by using this workspace and moving the probe to where you think it is to capture the MCA signal. So it's got both the autonomous feature and the manual feature, as you can see.
And I just want to point out here again, you lost the signal, so you want to research the signal, and these are the arrows that the robot remember that these were my signals. So to make your signal, the black one is your current view, and manually you can move it on the side and almost like, oh, beautiful signal. No, I'm all set, pause, and you're ready to monitor that.
Okay, folks, we've got 8 minutes left.
Yes, we're almost there.
Okay. So this study is essentially talking about a TEVAR deployment with the Sentinel. So they were looking at was the debris that they pulled from the
Sentinel, of course, comes in from the arm. It's got two baskets. One goes in the left carotid and one goes in the innominate artery. It doesn't protect the left subclavian or obviously the left vert.
And this is a capture device, not a deflection device, so it does capture the debris into the filter that you can retrieve to look, and that's what exactly what they're doing right here. So when they looked at the debris that they captured through these filters, this is essentially what they found. that there's all kinds of debris found in this, and a lot of it is actually acute thrombus mainly, and there's also some organizing thrombus and some arterial wall present as well. So there's another study done that looked at other sources of hits during deployment during TEVAR, and this showed that there's actually air being deployed as well when you're deploying these grafts, and not just debris that can occur during the procedure. This is another study kind of looking at the debris captured in various procedures, TEVAR, TAVR, TMVR as well. And as you can see that most of the debris captured was acute thrombus and organizing thrombus, and the calcification was very minimal. So these are the current embolic protection devices in trials or approved. The only one FDA approved right now is a Sentinel device, and this is a 140 micron filter size. It's inserted through the right radial with a 6 French sheath, and it covers only the innominate and the common carotid, like Dr. Lumsden was saying. It's a filter capture device, and it doesn't deflect. It only offers about 75% cerebral protection, leaves out some of the cerebral protection, of course. And the TriGuard 3 just came in with a Reflect 2 trial. They're still working on bettering their device in order to actually have complete deployment. It doesn't show that it's any better than the Sentinel or any worse than the Sentinel right now. There's also these current trials that are going on with some of these devices. This shows that, like I said, the Sentinel is the only protected device that's approved by the FDA right now. TriGuard 3 and the Embolic are close to being approved as well. And the TriGuard 3 is CE marked.
And so these are all being tested for TAVR, though?
Yes, all being tested for TAVR. They're being used as off-label in TMVR and in TEVAR as well, but nothing approved yet.
Okay.
This is actually our in-house system of device capture during our procedures. This essentially enables us to capture device data from the TCD as well as vital signs. So we're capturing the map, we're capturing heart rate, we're capturing blood pressure simultaneously to see how they correlate to the waveform changes in order to correlate to see what's going on in the actual procedure by phase. So this, we correlate back to our quad to make sure that we haven't missed anything during the procedure, so we can go back and refer back to it and make sure that everything went well. And I'll pass it on to Dr. Lumsden to talk about remote proctoring in its current state.
Yeah, so told you there's two problems with TCD. Number one is most places don't have the expertise to put the head frame on and to acquire the signal and maintain the signal, because one of the other challenges is sometimes during the case the head gets moved, you lose the signal, and then the TCD tech's got to get back in there and reacquire it. So the robot, albeit a little more expensive obviously, will solve the problem of acquiring the signal and reacquire the signal if the head gets moved. So that's looking at one solution. The second solution is who's going to interpret it. And so we came up with remote monitoring largely because Dr. Garami, his family for a while was in Budapest. We're now glad to see they're in Houston. But he'd go back and visit his family, and I'd have a stent graft to put in. And so here he is, basically. This is him peeking over my shoulder here. We are transmitting to him directly. You can just see it in the bottom of his screen. That shows you the fluoro signal of what I'm doing and the transcranial Doppler signal. And he's looking over our shoulder and telling us what is going on inside the patient's head. But he's doing that from Budapest. And so this is something where, because there is limited availability of expertise around the United States, the interpretation could be centralized. You don't necessarily need to have an expert actually sitting there. And so we've kind of built this for the Methodist hospital system, and now several of our partners, many of whom have trained here and gone out, have become so comfortable with TCD that Dr. Garami can actually monitor them from basically almost anywhere. And this is just an example. And he can, we actually now wear a Bluetooth earpiece, which connects directly into that remote viewing system. And so it's kind of crystal clear, you know, what that communication is actually going to be. So this is just another example, you know, of how it was being used basically in carotid arteries. But I think we're we're getting to the end of the evening. So we've covered a lot of ground here tonight. I would say that I believe this is the gold standard in cerebral monitoring. And I believe it's the gold standard, particularly for the kind of procedures that we are doing up and over the aortic arch, because of the immediacy with which it gives you feedback. I compromised the carotid artery, I get a signal that tells me there's a problem. Now it may compensate and go back to normal, and then it gives me a lot of confidence not to go ahead and do that intervention. Or there is immediate loss of middle cerebral artery signal. What are you going to do then? You're going to shoot a cerebral angiogram, we're going to confirm it, and we're going to go to neurosalvage. And so these are the kind of ways in which this can directly help a patient. Above and beyond that, there is no question that this cerebral embolization is an issue, even if a patient is not symptomatic. And it's fascinating to me that all the physicians who told me, really, it's not that big a deal. It happens, the patient's fine. All the companies that tell you, don't worry about it, not a big. All of these companies are now building embolization protection devices. And so I'm always going, okay, now help me understand. I'm just a simple guy, You're now building another device that's going to cost me another $2,000 to $3,000 to solve a problem which 2 years ago you reassured me wasn't really a problem. Why would I do this? Oh, because nobody now recognizes it as being a problem. So it is an issue. And I think we're going to have to mitigate this in some way. And I really think transcranial Doppler is the only thing that gives you real-time feedback. Because the problem is if you get an MRI post-procedure, it tells you the composite effects of everything that happened during that operation. I want to know that I did X down here and there is significant embolization. That is more than likely the cause of the stroke that the patient actually had. So, the end is nigh of the 60 minutes. I don't know if there are any questions because I forgot to announce that you could actually take questions. And so
we don't take questions.
We probably don't need to take any unless somebody figured out on their own how to actually do that. But if there aren't any questions, let me say thank you, Dr. Garami and Dr. Sinha. I thought it was very stimulating. I always learn something. Thank you for joining us. Thank you to Medtronic for supporting this.